Informatics for the National Association of Community Health Centers. And her presentation is going to be Phase 2 of COVID-19 Task Force. Welcome, Julia. Good to see you.
Thank you so much for having me. I apologize that I'm running behind. I'm in my clinic at NACHC in Virginia today. So I will be sort of talking to you from the front lines, literally. Can you see the slide view of the presentation, everyone?
Yes.
All right, great. So I'm just going to tell you a little bit about our COVID-19 multi-state data initiative with the Centers for Disease Control, and I'll jump right in. So I just wanted to give a couple of slides about our informatics work at NAC. And if you're not familiar with the concept of informatics, I think of informatics as a triangle that looks at people, process, and technology. I put people always as the biggest cog in the wheel because informatics thinks always about how do people do their work, what's most effective, what gives us the best experience, and how do we let people drive the technology and the processes that we're using. These are just some of the activities. Oh, hello?
We're not able to hear you.
Oh, what seems to be the problem?
Yeah, after slide 2, we were not able to hear you, and it looks like you're not able to hear us either.
Okay, yeah, I guess not, but I don't know what changed. Let me try leaving the computer audio and rejoining it.
For what it's worth, I can hear you just fine.
Oh, am I good again?
Okay.
I just heard someone say they can hear me. Can they hear me?
Yeah, but she's the other
Yes, this is
presenter.
Victoria Burns. I can hear you.
Huh. I wonder, did you lose your audio connection in the room maybe? Yeah, so a couple other people can hear me remotely.
I'm able to hear you online. Lindsay, is the room able to hear the speaker?
No, we're not able to hear you. Yeah, we're trying to figure out. But maybe we can improvise. Maybe I can have you hear the All right, try to speak and see.
Can you hear me now?
No, it's here. I have her on the phone. I will have you on the phone if that's okay then.
Yeah, that's fine with me. If folks can hear, and hopefully it doesn't generate any terrible feedback. I will, I'll start over on this slide right here. So what I was saying was, if you're not familiar with informatics, informatics is sort of the triangle between people, processes, and technology. And I always put people as the largest sort of wheel in this machine because people should really be driving technology and processes and not the other way around. A lot of people have the impression that they can use technology tools to somehow overcome deficits in their process or problems with the way that people are working or engaged, and that's actually not true. It should be that we redesign technology and processes to support people. There we go. So the NACHC, and that's the Clinical Affairs Division, is where the informatics team lives. And our team sort of helps to build and support public health data infrastructure and a governance model that can help us understand community health centers and how they work and what their patients are going through. Also to advocate for better technology and data processes that affect health centers, including working with vendors, working with the federal government, working with other public health partners to improve data movement and data standardization, and then working on some tools and workflow design improvements using human-centered design that can help to reduce burnout and make our work better. And that includes all the people in the care team and not just providers. And we sort of try to bring all that together to help everyone build skills in this space, regardless of whether or not that's their primary work role. So there are 3 things that we really focus on as really important tools to improving the way that we work with informatics, and that's good data quality and feedback. So we can generate all the data in the universe, but if we don't tell people how they're doing and what their data shows, we won't see any improvement. Even if they're improving on the ground, the data won't improve and it won't show us those improvements necessarily. And we also want to use data to help coordinate care. We know the United States has massive numbers of care gaps. Most patients don't get all the recommended services that they should have. And part of the reason for that is because it's not evident to the care teams what patients need what and what the priority of that to the patient and to their conditions is. And then we know that there are a lot of requirements on you all from public health reporting. We want to make sure that you're getting interoperability of that data that you send out. So again, you could use it to make your care for patients more comprehensive and to demonstrate that feedback and quality to your teams. Why are we doing this? Well, sadly, this week, as you know, the Washington Post reported that the United States deaths from COVID pandemic have passed that of the 1918 flu pandemic. And I think there are still many opportunities for us to get better and to prevent more morbidity and mortality with the work that we're doing. So this is the COVID multi-state project. The graphic that you see on the right here encompasses all of the different components of work that health centers do, right? You're doing surveillance, screening, and testing. You're following up with patients, and that includes case management of cases, reporting activities, and contact tracing. Many of you are doing that. And you, especially in the networks, are doing analytics to try and help us, augment the response. And some of the outcomes we're really interested in are how does the health center performance, how is your work affected by COVID-19? I'm sure you have lots of answers to that. How are patient outcomes affected? And we're thinking not just patient outcomes like the patient died of COVID, but what's the impact of not having blood pressure controlled? How many childhood vaccinations have we missed? Informing how we might improve both the regular care things that we do in the context of COVID and also some of the responses to COVID in terms of getting patients a vaccine, making sure we're testing the right patients. And then, of course, we use our registry data to inform the local, state, and particularly the national response efforts as we're working with CDC on this project. This is a summary of what we did in year 1 of the project, which again is sponsored by the CDC under a cooperative agreement with NACHC. In the first year, we had 6 HCCN and PCA partners. They're shown in these dark blue states on the map, but they have health center members in the light blue states. We have a fair amount of distribution across the country. We built in year 1 an infrastructure for data aggregation so that we could gather real patient level data from partners and analyze that at the population level. And I'll show you some of that analysis in a moment. We also worked hard to learn about some of the burdens and challenges at the health center and network and PCA level of COVID-19 and to put that data forward to partners, including actually HRSA and the White House, along with the CDC and some of the AACHCCVN state and local public health partners. So we reuse data definitions wherever we could, like those from CDC, those from UDS, those from the C19 Interoperability Alliance. And now we have nearly 1 million individual patient records of patients who had COVID services or were being treated by these health centers during the pandemic. Our data strategy, as I just said, is to pull data at the individual level so that we can roll it up to these other levels. This year, we're planning on doing some more analysis at the household level as much as we can to see if we can identify people who live in the same house and have increased risk related to that. But also, of course, looking at the community and population level. When we just gather aggregate data, we actually can't break it down to do multiple layers of analysis. So I'm going to talk briefly about our data infrastructure because it's usually of interest to people who are thinking about providing data to NAC's data infrastructure for public health. So I want to clarify that NAC's public health data infrastructure is not like an HIE or an HCCN. The purpose of those data infrastructures is to coordinate care and record information about specific patients. While we have patient level data, we don't carry patient identifiers. So our data is strictly for, the purpose of quality improvement and informing public health efforts. But we do try to work along the principles that are described in this slide of being flexible. So we don't require that everyone is able to reach the same standard of their data. We provide flexibility. So people say, well, I don't have RX norm data, I only have NDC data. We'll provide mappings and help to transform that data. The system, we have it in the cloud, in the Gov Cloud for Amazon Web Services. And so we can create very large data sets. Actually, the whole database right now is almost 2 million patients, and we can provide large scale queries. So we're really using big data, and we've only set the system up in the last year. And then, it's important for us, again, to bring the human perspective back. We have a strong need to document, archive, and manage our understanding of, the data that we have. And so we're trying really to, improve the quality and the responsiveness of our dashboards and also the documentation around the system and how it works. This is a schematic of the data architecture. So we take data from our partners, we map it to a data dictionary. It comes in through either a data staging or loading area or an API, and then it goes into our data lake. We use some tools like Databricks to normalize that data. We have basically data marts for each one of the projects. So when the data is processed, it can be upgraded into a data mart where it sort of lives with the other data for that purpose, right? So for this, in this case, it would be the other COVID data partners, and we can perform analytics. We can do research, but most of our work is not research oriented, it's quality improvement oriented. So we work with the CDC to help them understand what's going on with COVID and also to provide feedback again. We do have a terminology service, as I mentioned, so we can help organizations to transform data. And we're more than open to talk to folks about how terminology service or what mappings might help people to transform their data successfully to use it in the field. We actually have added a service from Say Medical to this year's project called Waypoint. So you can teach our database what your data means and how to transform it. And then you do that one time, and every time our system sees your data, it knows, oh, when it says HCID, that means the health center number. This project, unsurprisingly, has a great deal of data variability. So when we ask people, send us your test data, they have all sorts of things in their system that describes, the test. And some of those things are formal codes like Flint codes, and sometimes it's something that someone free texted in. And so it's a lot of effort to normalize these things over our data set, but it's definitely worth doing because we can help teach the partners in the field, including the vendors and the government, that they need to help standardize and have approaches to, bring these things into a way of describing them that is accessible to everyone, and where we can actually bring the data into large data sets and use it appropriately. I like this slide. It was created by our software engineer and architect. Oh, that was my bad. I'm trying to get this little thing off the top of the screen so I can see the words. But as you can see, sort of the process of cleaning up large data sets is just like sorting a giant pile of Legos, right? We take what looks like a big mess and we try to sort them, and then we can arrange them into components. We can organize them to look at them in a pretty way, but then what we really want to do is use that to tell a story. And that's where we're going with our data set here. And let me go to the next slide, please. There we go. So I talked about sort of the variability of data. And so, even something that should be as standardized as labs is very diverse and unstandardized. So the first one on this list, I think it was put there on purpose for me. This is one of my favorite test results, negative. So we're pretty sure that negative is a typo. That means negative. It's not clear to us why people are free texting test results into their system, but it doesn't matter why. In this case, we need to know which tests are negative and which tests are positive. So we go through the activity of helping to normalize this. And I think one of the things that we've learned, and one of the things we're working on a curriculum to help other folks, is how do we normalize these things before the data gets captured so that we don't have the onerous task of normalizing large amounts of data that becomes non-standardized. And that's something, especially as organizations are working to move with FHIR, Fast Healthcare Interoperability Resources, which is the FHIR here, that they have those mappings standardized so that when people are trying to send and receive data in FHIR, it finds the right data in the system. These are just some more examples of non-standardization. It's not a bad thing, actually, to let people capture data in the way that it naturally lives, but we need to teach the system how to create a shared definition of that so that when you go to find education, you don't get literally hundreds of answers that all mean 8th grade. One of the things that we include in the project is social determinants of health data. We formally use PREPARE as our sort of data dictionary definitions, but we are working actually with a couple of partners to understand how do we map other STOH data sets to PREPARE. And we work, as you know, NAC was a co-creator of PREPARE. We work closely with AACHCCCVN on this project. They have an RWJ project on normalizing social services and essential services, but also we're working to understand how we might put PREPARE domains forward in USCDI and the FHIR Gravity Accelerator. Just going to show you a little bit of data so you can see what we've been able to generate. I actually, on this bar, I hid the names of each one of the partners here so that you don't know whose data are whose. But this is 5 of the partners in our original project. And so this is an example of some of the dashboarding that we're doing. This is each organization's testing and vaccinations by month. You can see in the bottom there, the green is influenza and the blue is COVID. There's a lot of variability across our partners, and in some senses that's from size, and in other senses it could be things like they had earlier availability of vaccine or they have different patient populations. This is all the rest of these charts are going to be aggregated data over the 6 partners from year 1. You can see this is first dose and second dose distribution from January to June in health centers in our sample. And this looks at COVID diagnoses over the period starting in February through the period. Really, this probably doesn't include any June data, and this May data might be incomplete, but you see exactly sort of what we saw with the pandemic nationally, right? There was a surge towards the beginning of 2020, and then a lull, and then a big surge in the winter, and then things started to die down. I'm sure our current data, which we're just processing now, will show a new peak as we move through the end of 2021 in the Delta variant. We can see interesting things that can help us actually to advocate for health centers, like health centers vaccinate uninsured patients at higher rates than insured patients. So they are acting as that safety net for COVID vaccination, even though members of the community can go to other sites theoretically and get free vaccines. As expected, we're vaccinating more older adults, people who are in high risk categories. And then we do see some patterns and differences in healthcare vaccination rates by race and ethnicity. I should say that all of these data are still being validated and processed, but we think that most of these patterns are in part because of the fact that health centers, different health centers in our sample, target different populations, and the access in those communities may be different from location to location. So I'm going to just talk a little bit about COVID interoperability challenges before I close out. We did ask everyone to do an interoperability challenge in year 1 and are asking them to do that in year 2, but each partner got to pick what that was. So several of them worked to get feedback from their IIS systems. At least one did national electronic case reporting with the CDC's ECR Now, and several participated in data quality initiatives where they internally tried to improve the standardization of data. So this is a schematic of ECR. Now it's a CDC application that helps you to take all of your reportable conditions and automate those reports and send them over in one lump. And the ECR Now folks are working with the local and state public health people to try and allow them to get copies of those reports basically in effect, so that you wouldn't have to report separately at a local and national level. You all are probably familiar with IIS systems. So we've been doing a lot of advocacy with the CDC and ASTO and others to try and help them recognize that it's just as important to send data back and make that available in bulk to healthcare providers so that we can target all of our efforts on the people who really aren't vaccinated, instead of calling people who got vaccinated down the road and we don't have that information in our systems. So at the very beginning of our work in 2020, these were all barriers listed, anticipated barriers listed by our partners. And we found that all of these, in fact, were challenges that they face. The lack of standardization and centralization of data is a major problem. Patient matching is not consistent across locations and settings of care. Lack of EHR standardization in the data that gets extracted, problems with getting these extracts from the system, no access to claims data or poor access to that, and then problems with inconsistent documentation and self-reporting. Obviously, those same principles extend actually to COVID vaccination data, right? IIS systems usually don't allow bulk queries. They often don't allow an easy feed of data back to primary care doctors. And so, we even found some sites that use networks to gather their data, that the network can't access the IIS system. And so they had to do individual queries. Obviously, that's basically only one tiny step up from calling patients. Not very efficient, not very effective, and not very timely. There were a lot of issues, especially early on in the pandemic, with the consistency of reporting to IIS systems. So we continue to find that patients who were vaccinated actually don't have a report in the IIS, and corrections need to be made. So a lot of opportunity for improvement, but we're right there, advocating for all of you on the front lines as much as we can. This is the timeline for year 2 of the project, actually. So this year we're bringing on 4 new partners, trying to expand our reach and learn more from different kinds of partners. We're integrating the waypoint mapping tool, as I mentioned, and continuing to work on our dashboards and feedback. We'll be doing more and different kinds of validation testing this year, working not only with some of the point of care records and doing some EHR abstracts, but also using some machine learning to say, well, does it make sense that you didn't give any vaccinations in this month, but you gave 10,000 the month before? That's probably not right. Let's investigate that. And then we'll continue to respond and innovate in phase 3. In year 1, we did not know if we would be doing a year 2 of this project. Sadly, we are still mid-pandemic. And so here we are moving into year 2. So we won't rule out the possibility that this work will extend for another year, but we think we've learned a great deal, and the CDC has been very excited about our work. So just to give you an idea of what NACHC does to support the multi-state project, we meet weekly with the CDC COVID response team. We both get information from them and share it back to the partners, as well as carry stories up, and we encourage the individual partners to actually meet directly with the CDC response team to tell them your stories. That's very impactful for them. I think they've said that was some of their favorite parts of the project, was hearing from health centers and networks. We, again, like I've said, working with public health agencies to improve support for health centers, especially around data standardization and data feedback. We've been giving feedback back to the partners, and we're going to really make that very regular and fast this year. We're making updates to our processes based on the input we get from you. So if you participate, we'd love to hear more. And collaborate for opportunities for dissemination. We want all of our partners, as much as possible, to go out and tell their story at the national and regional level. And I think this is an example of that in reciprocity. So I'll stop here and see if there's any questions, and I'll put in a little plug for NACHC social media. Yes.